And then here, just a welcome. Again, this is the Moving the Needle Forward webinar where we will discuss the community-wide collaborative community health needs assessment. And we'll hand it over to Jackie Rouse, who will start introducing everyone and the agenda for today.
Good morning, everyone. I just want to introduce the agenda for today. And so we will look at a high-level overview of the Alliance for Health Equity, the Community Health Needs Assessment. And we'll talk about the process by which we use to collect data and the partnerships that we've developed. We'll also provide the actual data findings and talk about the community engagement and input that we use to create the data, and just really talk about implementation planning and what strategies we can use with the Alliance to create an impact. Next slide. I want to present to you our presenters today. We have Sherry Cohen, who is with the Chicago Department of Public Health. We have Kelly Day, who is with Ann and Robert H. Laurie Children's Hospital of Chicago. Katina Latham is with the University of Chicago Medicine. We also have Jamaica Sampson, Director of Community Health and Wellbeing from Mercy Hospital and Medical Center. And then Jess Lynch and Leah Barth and Andy Goodall will be also presenting with us today. And Jess Lynch will present Christopher Nolan's portion. Christopher Nolan is from Rush University Medical Center. Next slide, please. So what type of organization are you representing today? We want to find out who is on our webinar today. So we're going to do this poll. Will you please vote as to what organization you are with? And so looks like we have the majority of organizations are healthcare organizations at 50%. Then we have some community-based organizations, and a few of the health departments are on the webinar. And then also we have another group of other organizations that are participating today. If I may talk briefly about being a founding member of the Alliance for Health Equity, I'm on the steering committee and just want to talk about how excited we are to be at this stage of our CHNA process, and just want to talk about how Advocate Aurora Health has been really excited to work with the Alliance for Health Equity, and that allows us to really engage in a collective impact. It brings about the opportunity to partner with others to address our community's needs. And then it also, participating in the Alliance provides us an opportunity to learn and share and collaborate about the latest concepts in public health. And through that, we meet other organizations and other partners. And then most importantly, working with the Alliance for Health Equity has helped us to have a platform and organization for our data collection and analysis and reporting for our community health needs, and which is what we're really going to be talking about today. At this point, I will hand this over to Jess Lynch.
Okay, good morning, everyone, and thank you, Jackie. I want to give just a quick background on the Alliance for Health Equity for all of you. Today, we will be focused on the process for the most recent Community Health Needs Assessment. But as you will hear at the end of the webinar today, there are many opportunities to get involved in partnering around some of the priorities that have emerged from the CHNA, and that's where we're really excited to move with you all next. Next slide. So on this slide, you'll see the collective purpose for the Alliance for Health Equity that has been developed over the past several years. We wanted to really emphasize here that the vision of the Alliance for Health Equity is to advance health equity across the city and suburban Cook County, and to really support both collaborative-wide initiatives as well as local and regional initiatives that are happening in communities across the county. This is a partnership to really focus on addressing social and structural determinants of health, and we'll get into some of the details on that in a few minutes. Next slide. Here you'll see the hospitals that are currently participating in the Alliance for Health Equity. All of these hospitals and health systems were a part of the collaborative community health needs assessment. Did want to note that Cook County Health, as a public institution, is not required to complete a community health needs assessment. So Cook County Health has been involved with other work groups and collaborative initiatives of the Alliance, but not specifically with the CHNA. Next slide. So we also wanted to really highlight some of the partners that we've worked with throughout the community health needs assessment and implementation strategies process around a whole host of issues. This is not an exhaustive list, but we wanted to limit it to folks that we've actually done some type of specific project or community input session with. If you have been actively participating and don't see your logo here, that was not intentional, and we're happy to add that if you want to send us a note. Next slide. So I think many folks on this webinar are familiar, but just wanted to give a quick background on community health needs assessment. First of all, as we've mentioned, the Chicago and Cook County Departments of Public Health are crucial partners in the Alliance for Health Equity on the steering committee and in founding this effort back in 2015. Both CDPH and CCDPH have been working on community health assessment and community health improvement planning for over 20 years. So we're really fortunate to have that expertise in our area. Back in 2012, under the Affordable Care Act, nonprofit hospitals were required to conduct community health needs assessments every 3 years. And the Alliance for Health Equity formed when a number of community partners and hospital partners determined that it made more sense to try to work together to have a greater impact around the issues that emerged from the assessment versus each institution doing their own. Today, we'll be talking about the second round of collaborative CHNA that just wrapped up. Next slide. In the interest of time, we're not going to go into depth, but we wanted to make sure that everyone had this information in terms of the full process that we conducted, and you'll be hearing about most of this today from partners that were involved. Did want to point out that in the handouts tab of your webinar platform, you can download all of the slides from today's webinar to follow along. So you'll be able to have the details there if you need them. Next slide. So we really wanted to emphasize that it has been really crucial to come up with a unifying framework around health equity that we can all share and work from. And this framework that comes from the Bay Area Regional Health and Equities Initiative is one that the health departments, hospitals, and community partners have coalesced around. And Sherry Cohen from the Chicago Department of Public Health will speak shortly about how CDPH has been adapting this. But you'll see that we also built our CHNA around really thinking about the social and institutional inequities that exist within our communities and our society, and making sure to build that into the way that we're thinking about looking at data and community input. Next slide. The last thing before I turn it over to Sherry that I wanted to mention is that the Chicago and Cook County Departments of Public Health are on slightly different timelines for their respective dates for community health assessment and plans. As you'll hear, we have shared data across the hospital community health needs assessment and the city and county health department processes. We'll be hearing from the Chicago Department of Public Health today since their process is further along. Again, this is dictated by their accreditation cycles, and you'll see that the Cook County Department of Public Health will be kicking off their process later this year, and certainly many of you all will be involved in that process as well. So at this point, I will turn it over. So for those of you who are interested in getting even more information than you will today, there's several hundred pages of reports that really thoroughly document the data and particularly the community input that came through this process. And so you can see here that the Community Health Needs Assessment is available on our website at allhealthequity.org. And that includes both the comprehensive Community Health Needs Assessment report, a separate focus group report that really hones in on the focus group data you'll hear about in a few minutes, a community input survey report that really hones in on the community input that we received from over 5,000 residents across the county. And you'll also be able to find links to all of the individual hospital CHNAs that you'll hear more about today on the webinar as well. Next slide, please. So within the CHNA reports, you'll see that community input is integrated into every chapter, and the outline of the CHNA is included on the slide here so that you can get a sense of the breadth of information that is included there based on the input that we received and the data that we worked on in collaboration with the Chicago and Cook County Departments of Public Health. Okay, so we're going to go ahead and transition into hearing about the community input that I mentioned. And not to worry, we will at some point be getting back to Sherry to hearing about how this integrates with the health department. But we're going to move into the community input at this stage, since I know that's why a lot of you are here.
Hello, everyone. We're recording this part of the webinar on June 13th. But we're going to be going over the community input collection that was completed as part of the 2018 to 2019 CHNA Community Health Needs Assessment. So we collected community input through 4 methods in partnership with Alliance partners. We distributed a community input survey between fall and early winter 2018 to 2019. We also conducted focus groups through the Alliance for Health Equity and in partnership with Westside United. There were focus groups completed with healthcare and social service providers, as well as 2 stakeholder assessments that were led by Chicago Department of Public Health and Cook County Department of Public Health, looking at the forces of change that can impact health and communities, as well as understanding capacity to address health equity within the public health system. So the purpose of collecting community input, we had 3 overarching purposes. To understand the current health status of communities, so we asked questions such as, what communities think are the best things about where they live, work, and play? What is making communities healthy or unhealthy? And what are the top health needs or issues in the different communities across the county? We also asked about barriers or facilitators to a healthy community, such as how easy or hard is it for you to access healthcare or mental health treatment or substance use disorder treatment when you need it? What types of programs or services are available in your community for children, for older adults, for other family members? How do we improve health equity? Like, what are some social and economic strategies that can be used to address the inequities that community residents are seeing every day, as well as strategies for addressing health needs? So we want to understand, what are community priorities around what needs to be improved most, and how can hospitals, health departments, and community-based organizations work together to address those needs? We also want to know how communities, what role communities see themselves playing in the solutions and strategies that they suggest. So Alliance for Health Equity and Partners focused on gathering input from communities that are underrepresented in assessment processes, as well as those who typically face a disproportionate burden of health inequities. So it's important to remember that this wasn't random sampling. We very specifically reached out to certain communities to hear about the biggest health equity issues that they're facing. So some of the examples of the populations that we're focused on for both the survey and focus group were immigrants, LGBTQ+, veterans, justice involved, low-income families with children, homeless youth and adults, older adults, and ages in the focus groups range from 14 years old or older. The survey was distributed to adults 18 years or older, and we got participation and responses from a diverse group of racial, ethnic, religious, and socioeconomic backgrounds.
So to start a little bit about the community input survey, like Leah mentioned, the survey was collected from August 2018 to February 2019, and during that time we collected 5,934 surveys. On the right-hand side, you can see the geographic distribution of survey respondents. Respondents were asked the question, what is your zip code? And that is how we've mapped this. You can see that we received responses from all over the county with a slight skew in the west side of Chicago. We're very thankful for our partners for helping us collect these surveys. Some of our key data collection strategies included partnering with organizations in key communities. So hospitals and community-based organizations work together to collect these surveys. Some great examples of that would be our champion students, which are high school students that are convened through a UI Health program, and they went out into the communities that they lived in to collect over 1,000 surveys. Additionally, to uplift the immigrant community, we had help from the Polish American Association and Chinese American Service League to distribute our surveys that were translated into Polish and Chinese. Additionally, we had meetings to discuss survey collection with partners to find the best approaches to getting responses from our different respondents. One of our priority populations, as I mentioned, was immigrant communities. And so we would have meetings to discuss where is the best place to meet the respondents where they are, how do we show this as a benefit to their community and explain the importance of community health needs assessments and having their voice uplifted. And then lastly, translating the survey so that it's appealing to all different groups. So we translate it into Spanish, Chinese, Polish, and Ukrainian. And then on the bottom left, you can see our priority populations, which Leah also mentioned earlier. As just a review of some of the demographics that we have here, from the survey, we collected almost 600 surveys in Spanish, about 150 surveys in Chinese, and then about 100 surveys in Polish. One thing that we noted was that the Polish community, while some took the Polish translation of the survey, some respondents felt more comfortable selecting Polish as an ethnicity and taking the survey in English. Additionally, we asked demographic questions about if they had someone living in the household with a disability, and have had about 1,500 responses from that community. And then additionally, we asked about sexual orientation and gender identity. So we had about 400 responses from the LGBTQ+ community. And then finally, we asked about annual household income, and had about 1,700 responses from individuals with households with incomes less than $20,000 a year. Some of the key factors for a healthy community that came out from the survey were access to healthcare and mental health services, safety and low crime, access to community services, access to healthy food, and affordable housing, which aligns with a lot of the overarching topics that we found in focus groups. We also asked about the most important health problems in their community, and diabetes, mental health, age-related illness, substance use, and heart disease and stroke came out as most important health problems. And as we looked at the service areas for hospitals in smaller regional areas, we found that these health problems emerged as the top 5 even in the smaller communities, with sometimes other chronic diseases such as cancers and obesity coming up in their top 5 in the smaller regions. Additionally, we had 2 open-ended questions. One open-ended question was, what would you like to see improved in your community? These were written in responses, which were then coded and to overarching themes. And so that is where we got the themes of safety and low crime, economic development, infrastructure, community cohesion, and healthcare. The second open-ended question was, what are the greatest strengths in the community where you live? And the codes and overarching themes were community cohesion, community services, safety and low crime, transportation, and education. And as you can see that there was a little overlap from what respondents would like to see improved and what respondents would consider greatest strengths in their community. And we did some brief mapping to see how this looked and found that in some communities, respondents would say the greatest strengths would be safety and low crime, and then another respondent in the same zip code would say something they would like to see improved is safety and low crime. So that was something interesting that came out through this survey, the different experiences of respondents. So to get a deeper understanding of our priority populations, we did cross-tabulations of responses from those who identified as different priority populations and their responses to the multi-select questions. What do you think are the 3 most important health problems in your community? And what do you think are the 3 most important things necessary for a healthy community? And as you can see for the LGBTQ+ respondents that we pulled out, that mental health, substance use, and violence appear more often in the LGBTQ+ community of respondents. Additionally, for the question, what do you think are the 3 most important things necessary for a healthy community? You can see that for LGBTQ+ respondents, the access to healthcare and healthcare and mental health services really appeared more often, and same with safety and low crime. Whereas for the overall respondents, access to community services seemed a little bit more of a priority. And we did the similar crosstabs for older adults and younger adults to kind of see where their priorities lie and how we can address these needs on a more community level for them. And as expected, older adults prioritize things like age-related illness and chronic diseases such as cancer, diabetes, heart disease and stroke more frequently than younger respondents. And then on the opposite end, younger respondents prioritize mental health, STIs, STDs, substance use, and violence more often than older adults. And then for the things necessary for a healthy community, there wasn't as much variation in the responses, but you can still pull out that for younger adult respondents, access to healthcare and mental health services was more important. Additionally, safety and low crime, which echoes the health problems question. And then interestingly, clean environment really came out as a priority for young adult respondents. For older adult respondents, access to community services and transportation were clearly more important, and does align with the chronic disease and age-related illness health problem responses.
Great. So for focus groups, we completed 57 total in partnership again with Westside United, which is a regional group of hospitals working together on issues specific to communities on the West Side. The 31 focus groups were conducted by Alliance for Health Equity staff, and 21 learning map sessions were conducted by Westside United. And Alliance for Health Equity worked with Westside United to make sure that the questions and info that we collected overlapped between these 2 types of sessions, so that we both had useful information that could be gathered from the 2 different types of community input collected. We also conducted 5 focus groups with service providers and community leaders And how we reached out to these organizations is primarily through our hospital, health department, and community-based partners. We asked them for recommendations on the communities we should focus on, and they really helped to drive the connections and our ability to arrange to conduct focus groups in these different communities. What you see on your screen is a list of the focus group host organizations where the focus groups took place and the Westside Unite Learning Map sessions took place. So what communities told us is that there were 4 overarching themes, and then we had 3 cross-cutting themes that really permeated all of the discussions. So racism and discrimination, safety and violence were topics that came up, whether we were talking about behavioral health, access to healthcare, chronic disease, healthy lifestyles. Those issues permeated, again, all of those discussions. Community cohesion was another cross-cutting theme. So community cohesion, meaning the connection that people feel with their neighborhoods, with their communities, and understanding that these communities have a lot of knowledge, they have power, they understand the solutions that are needed to address their health needs, and that it's really important that their voices and that their expertise be used when implementing strategies to improve community health. The other 4 major themes that were discussed, behavioral health was the top topic discussed by focus group participants. Access to healthcare and community resources was the second most discussed topic. Social and structural determinants of health, as well as how those social and structural determinants influence other issues like chronic disease or mental health, was another top key theme. And chronic disease also was a prevalent theme across the focus groups in the city and county. So for mental health and substance use disorders, there are a few key takeaways. So trauma and chronic stress are extremely prevalent in the communities that we talk to. And this trauma and chronic stress are underlying root causes of poor health outcomes and also social determinants of health, such as violence and poverty. Homelessness, mental illness, stress, and trauma are both root causes and direct outcomes of substance use disorders. A lack of mental health awareness and education leads to stigma, worsening of mental illness and substance use disorder, poor overall health, and lost lives. And when we spoke to providers and community residents, they all agreed that access to mental health and substance use disorder treatment and services is critical for a community to be healthy, but almost universally access to these types of services is lacking in those communities in Cook County. So some of the examples of responses we got from participants include like the importance of having services to support folks who are going through trauma and chronic stress. That there's a lot of stigma and that's impacting individuals' ability to access the care they need. That patients are traveling far distances and really struggling to find providers that take public benefits, that take private insurance. There really is a lack of not only provider availability, but like geographic and logistical access to services. And that when these services are lacking, we again start to see other issues like substance use disorders, violence, continuing generational trauma that continue to perpetuate and pop up in the communities we spoke to. Again, access to care was the second most discussed topic. The key takeaways are that policy changes are making it more difficult for communities to access private and public benefits. An example that came up repeatedly when we spoke to immigrant focus groups is the draft public charge, and how that has made several communities scared to access public benefits with the fear that it might affect their ability to get citizenship status. Another issue that came up is like changes to how medical cards are distributed and how long that takes is really impacting how quickly people can get care when they need it, with wait times sometimes going as long as 6 months to a year to get medical card for basic needs like vaccinations for babies. There are profound differences between communities in the quality of healthcare available and received. This was particularly highlighted by individuals with disabilities, individuals living with mental illness, and communities of color. It was loud and clear from what participants said that they feel that often they are not receiving the same quality or level of care that other groups of people are receiving. Many families are struggling with inadequate insurance coverage and limited provider availability, and this is particularly true for those receiving public benefits and veterans benefits. And again, this links back to mental health care. These issues are cross-cutting between access to healthcare and mental health services. And then many communities lack affordable community-based services. And another group that we spoke to in particular, so that lacking insurance coverage and access to healthcare can really cause stress and trauma for people who are not well and need help. So some examples, again, the quotes here talk about how like the administration and government policies, even if they aren't implemented yet, are affecting how immigrants are accessing care, how our bureaucratic system for accessing public benefits is causing delays in care and difficulty for people receiving appropriate care. And not having health insurance definitely, again, just like public benefits, impacts when people seek care and how serious their conditions get before they actually receive the help they need. For social and structural determinants of health, a lot of the discussions around social and economic factors is how inequities in economic investment and development, employment opportunities, transportation resources, quality affordable housing, education opportunities, and healthy food access are really driving the health issues and health outcomes we see in communities such as chronic disease. So there are many factors, again, that focus group participants mentioned. Some of the key takeaways include that like the lack of new business investment and development in certain communities is due to factors such as long-term divestment by both private businesses and local governments, and that the loss of locally owned businesses, limited educational resources, low levels of home ownership, and minimal employment opportunities are making these problems worse. Communities of color are struggling with high rates of unemployment, and in communities of color where jobs are available, focus group participants describe them as part-time, temporary, or low-paying. Individuals living with mental illness, young adults, homeless individuals, and formerly incarcerated face significant additional barriers to employment, regardless of where they live in the city and county. Major education concerns that focus group participants mentioned included school closures, poor quality schools, limited resources for learning trades, a lack of support programs such as low-cost tutoring, and limited adult education programs. Youth of color face large inequities in employment and skill building opportunities. Housing instability, homelessness, rising housing costs, and poor housing conditions are all contributing to poor health outcomes in certain regions of the city and county. And these issues were particularly prevalent in the south and west sides of Chicago and the south and west suburbs. And there are significant geographic and financial barriers to accessing healthy foods in certain communities, again, primarily focused in the west and south sides of the city and suburbs. So for chronic disease, a lot of the focus group discussions really did, again, focus on how social determinants such as poverty, limited access to healthy foods, exposure to violence, and housing conditions are both underlying root causes and barriers to the management of chronic disease. For many communities, they described how education about preventing chronic disease, what the risk factors are, and when they should seek medical help is lacking in communities, and that there needs to be more dialogue between community members about the health conditions that are affecting them. Chronic illnesses such as asthma and diabetes can be isolating for youth, parents, and adults, especially when they feel they don't have adequate community or family support for managing those chronic illnesses. And a big solution that was mentioned is that additional community groups that share information about resources and support each other with adjusting to healthier lifestyles would be extremely helpful to communities. So again, if you look at some of the quotes, you can really see where focus group participants highlight disparities. In the south suburbs, we had young people who said, there's one gym, otherwise you have to go to another community to exercise. Youth on the south side of Chicago pointed out that they have a really high concentration of fast food restaurants, very limited access to affordable places to buy food or places to just buy healthy food, period, like Whole Foods or Mariano's. Again, another participant on the south side highlighted the need to have discussions within communities about the health issues that are impacting them. And again, on the south side, they mentioned how adults that were dealing with diabetes mentioned how social media, community groups, workout buddies really helped improve their ability to manage their condition. So those were the main key takeaways, again, for these 4 major themes and 3 cross-cutting themes. Behavioral health and access to healthcare being the top 2, social determinants of health being another important critical component discussed, as well as chronic disease. So although this webinar was recorded on June 13th, the folks who are live in the webinar right now would be happy to take any questions you have.
And before we actually wrap up, I wanted to kick it off with one question for you, Leah. So you mentioned that one of the things that was discussed through the community input was the role that communities see themselves playing in solutions. And you pointed to that in terms of the cross-cutting theme of community cohesion and how that ties into community power and solutions that many communities already know are working and can be connected back to some of the healthcare and public health institutions. So could you just speak a little bit more to what you heard from the focus group participants around community cohesion and how that relates to the collaborative solutions we can work on together?
Yeah, so I think one important thing to note is that communities who did have programs or services available said there's a lot of duplication of efforts, and that a lot of the efforts that are currently in place are not addressing some of the sort of like underlying issues. For example, a workforce development program was mentioned, but then they get to the end of the workforce development program and nobody has IDs from the state, and that makes it difficult for them to fill out any job applications. And so they said, you know, if they had spoken to community residents, that might have been an issue that could have been implemented into that or integrated into that program ahead of time. So refining programs that are already in place is one role that, or refining programs that are being developed is one role that communities see for themselves. Another, again, is like, where are resources going? So maybe we don't need 5 workforce development programs in our community. Maybe there are other issues that need to be addressed first, like housing or food security. So really making sure that the decisions we make about programs that we support or try to implement that are new, at least, we need to be taking a community-driven approach where we really take the lead from communities on what needs to be implemented. And also there are a lot of really great grassroots efforts that are being led by communities. For example, there are a lot of grassroots efforts around like community gardens or mentorship or tutoring programs, and that a lot of these programs just need additional support to keep running, to expand their programs because they're a successful evaluation, grant-making tools. So finding ways that we can connect with these community partners that are already on the front lines, and how can we support those programs that are already in place is another role that communities see for themselves, and also having a place at the table. So being a part of like our decision-making processes overall was very important to the community residents we spoke to.
Great, thanks. So thank you to Leah and to Andy for making that presentation. And we encourage you again to type in the questions or discussion points that you have into the question area so that we can discuss those at the end of the webinar. So at this point, we're going to continue on and hear from Katina, who's going to share with us about the secondary data within the CHNA and some of the work that University of Chicago Medicine has done to work with local communities to really localize that data. Take it away, Katina.
Thanks so much, Jess. Can you hear me okay?
Yes.
Great. Okay. Good morning, everyone. Again, this is Katina Latham from U Chicago Medicine. I first off want to thank Jess and her team and the Illinois Public Health Institute for their leadership on this project, as well as the other hospitals for the opportunity to collaborate with you. This was a long journey, more like a 14-month birthing process, so a labor of love for us. So I want to talk to you today about the secondary data that was collected. So this data was collected and compiled and analyzed with support from the Chicago Department of Health, Public Health, as you've heard, and also from Cook County Department of Public Health. This data was from over 20 sources, both local health departments included, planning, housing, police agencies, state and environmental, health and education agencies, as well as federal sources, including Census and the U.S. Department of Agriculture. Data from the surveys comes from Healthy Chicago survey, as many of you are probably familiar with, as well as Voices of Child Health in Chicago and the Behavioral Risk Factor Survey of Surveillance. So just wanted to give you the highlights of all the data that's included. And now we'll go to the next slide. And what I'm going to do in this piece is sort of walk through the chapters that are included in the needs assessment, just for your quick reference. And then we'll also highlight some of the data components for you to look at, but we of course encourage you to go and look at the resource, the full resource that Jess referred to earlier. So the first set of information that we'll review will be some examples of the health inequities that are highlighted in this report. And I'd say this was a special feature for us for this go round. It was a theme that we wanted to highlight throughout, and as you saw from the community input survey data we looked at, many times we wanted to make sure, to the extent that data was available, we could do sort of that comparison and look at inequities. So this in health inequities chapter highlights the inequities experienced in both the city of Chicago as well as suburban Cook County, and the importance of working upstream on structural issues such as structural racism, so we could then have more positive effects on health outcomes. And of course, as you all have probably seen, many of the infographics that have depicted health inequities of life expectancy, we have included this information in the Cook County CHNA assessment. And as you see, it's the one graphic at the top of the slide, comparison of life expectancy for suburban Cook County. For example, as you see with the blue people chart, or the blue men or women, or you see what in Glencoe, that the life expectancy is about 90 years, and that's when you compare that to the United States and Broadview and Riverdale, so suburbs in both the South and the West, comparing it to Glencoe, obviously more north, the life expectancy is less. So that's roughly between 79 to 71 years for the U.S. and then compared to those suburbs. Other things that are highlighted in the report are related to infant mortality when we look at rates per 1,000 live births. As you see, for infant mortality rates for African Americans, the rate is almost 4 times as much as that goes for whites or Caucasians, and then twice as much for Hispanics and Latino, with the rate being 12.7. Then lastly, I want to take you to the chart where we are sort of highlighting the effects of higher poverty with lower life expectancy. As you see depicted in the map, it's outlining that the pale yellow sort of colors, as you see, are more on the north side of Cook County that have the lower poverty and, of course, higher life expectancy. Then down to where we're more in the urban part or the core area of Chicago, where you have more of the darker blue with the higher poverty and lower life expectancy. So those are just some of the examples that are included regarding health inequalities. We can go to the next slide. On the same theme of looking at some of the social and structural determinants, there we have this other key section where we looked at how poverty and opportunity, education, housing, and community safety affects health. And research has long established that social inequities are the key drivers of health outcomes. And this particular chapter on social and structural determinants of health covers a multitude of issues to highlight the importance of addressing these determinants to change health outcomes. So this is all information that all of us on the call know, but I think for the importance of this chapter is it provides us the evidence to support it. And it provides this evidence at our level, meaning Cook County level, or even at certain community levels if you're interested. So some of the things that this chapter reviews are poverty and opportunity, as I mentioned, food access and food security, environmental health, and of course, community safety and violence. And one side, the data I wanted to point out to you is on the upper right of the slide regarding poverty status and educational attainment for adults 25 and older in Cook County. As you see, those with those with bachelor's degrees have lower income or lower percentage of those who are in poverty compared to those who are in high school. So we have, for those with bachelor's degrees, only roughly a little under 6% are living in poverty compared to those who are in high school, over 25% living in poverty. So again, it's information that we all know, but it's a readily available resource to use when you need to grab specific information regarding Cook County or the city of Chicago. Moving on to the next slide. So this slide is about access and quality to health care, and we wanted to highlight the information that is included in the chapter related to this. And we all know the primary areas of access that we focus on: affordability, availability, and quality. But what's nice about this chapter is that it goes beyond that. And we look at other things such as proximity and convenience, accommodation and reliability, as well as acceptability, openness, and cultural responsiveness, and appropriateness and approachability. So in some of the information that's included, we look at not just healthcare coverage, but also access to school-based health services. And as you see on the graphics depicted here, some of the infographics show the distribution of federally qualified health centers in Cook County. And as you can see, the larger concentration of those are probably more closer to the city of Chicago and fewer when you go to the suburbs area, both north and south. And it also looks at, you have charts regarding the uninsured in Cook County, so you can see the distribution of those without such coverage. Moving on to the next slide. Additional information we have included here, and of course you've heard on the community input survey, we gathered information from those in terms of what's important issues, and mental health, as we all know, is a top priority. And it was just consistently brought up as an issue to address community-wide. So this chapter outlines just the data that we gathered and have available there, and some of the key takeaways from the chapter, of course, the overarching need regarding just the quality and the fragmentation of the services and the need for the integration of care, but also things such as trauma and childhood adversity concerns and the stigma and discrimination that's attached with mental health issues. And then there's the workforce shortages and gaps in training, so that we can all see where our greatest needs and where we can do things such as capacity building for having mental health providers. The data that we present in this chapter, as you see, one is included here on the slide regarding the utilization of emergency care. We show mental health emergency department rate visits per 10,000 in Cook County, Illinois. And as you see, the communities that we serve, and more along the southern areas, such as the Woodlawn communities and Roseland communities, have the greater number of visits for mental health issues. So this was certainly important for us to have this data as we look in terms of how should we identify priority health areas to address. Moving on to the next slide. So the last chapter that I will highlight in the community health needs assessment is related to chronic diseases. So things such as heart disease, stroke, cancer, diabetes, arthritis, asthma, mental illness, as we've just discussed, and HIV and AIDS. These things we know count for almost all, about 90% of the nation's annual healthcare expenses, of the total 3.3 million that's expended each year on healthcare. So this chapter outlines the importance of prevention and management of chronic diseases and the burden of such diseases. And we have sections on prevention, of course, and then mortality rates. And specifically, some of the mortality rates highlighted are those related to asthma and diabetes, as you see in the chart here regarding racial and ethnic disparities in asthma ED visits, showing, compared to all races, that those who, African Americans, have the highest number of ED visit rates. And asthma, of course, is the #1 priority health area for us on the South Side here in the community that we serve. And so this data is sort of definitely used to support our efforts going towards that and helping us to then further understand what could be some of the underlying causes for the disease. Other things that are noted here, as you see, are the incidence of opioid overdoses in Cook County, where you see the darker shades of blue are the higher areas of opioid, and then the lighter areas. And you see on the chart, it's showing a stark concentration of area where the darker blue is in more of the sort of middle section of Cook County area. So that just wanted to wrap up and say that these are all information that's readily available, and we hope that it will be useful for you as it is to us at UChicago, as well as all of the colleagues that are part of the Alliance. On the next slide, I want to highlight how we've used this information, specifically at our community level. So this data is available by zip code and also by community levels, and we serve 12 zip codes on the south side of Chicago in terms of the area that we focus on for our community health needs. And among those, in that 12 zip codes, there are about 25 communities, and we took this data to do specific community profiles for all of our area. And as you see on this slide, it's just a snapshot of what that looks like, but we provide things such as demographics, social determinants of health, some of the physical factors, as well as some of the leading causes of death, and also resources that are available in that community. And this information has been used, as you see from our article reference here. The Hyde Park Herald used this data to compare the Woodlawn community to the Hyde Park community, and we encourage others to do the same. These are resources that help you to understand your community and also things that you can use to justify or prepare the information for funding. There's a vast amount of information that's been collected as part of this community health needs assessment. So not just our profiles, but all of my colleagues on the phone at this hospital, we're all using this information to help us further understand our community's needs. And we want this to be a resource for you as well. So we encourage you to reach out to the Illinois Public Health Institute for ways to do a deeper dive of this data, because now that we've done all the work, we think that you should share in it as well. Thank you so much, Jess. I think I'm done.
Thanks, Katina, and definitely want to echo your point that we at IPHI and all the colleagues on the phone are very happy to connect with anyone on the line. This data is for everybody's use and also everyone's analysis. So if you have thoughts about what you're seeing, please feel free to type those into the question box or email us afterwards. So we will hear from Sherry, and then following that, we will hear from Kelly Day from Lurie. So take it away, Sherry.
Okay, great. Chicago Department of Public Health, we worked in collaboration with the Alliance, with Cook County Department of Public Health, and the 42 member organizations of the Partnership for Healthy Chicago to conduct our community health assessment. And just so you know, IPHI, the Alliance, is a member of the Partnership for Healthy Chicago. So to develop all of these, I'm going to go through our goals. We used our vision, which is very closely connected to the Bar-High framework that Jess presented earlier in the webinar. So that's, you'll see as I go through all the different goals that we really connected here. But what this slide shows, sort of the downstream area with looking at life expectancy. And these data show that from 2012 through 2017, the gap between Black and white Chicagoans' life expectancy actually grew. And there now is an 8.8-year gap between Black and white Chicagoans. Also, even though the Latinx life expectancy was higher than white Chicagoans, it has had a steep decline in the last, 6 years, again, driven by the same areas that specific health conditions. I wanted to let you know that we will continue this work on these health conditions throughout that are also mentioned throughout Healthy Chicago 2.0. They've been integrated into the work that we do in our workflow. So all of these strategies will continue especially related to these areas which are really impacting the life expectancy gap. I also want to mention our third goal in this downstream area is increasing community well-being. That came out a lot in the different assessments. We do not have something specific right now, but it is a goal to really be able to measure that better, and then identifying great measures for that, and then being able to monitor it over the 5-year plan time that our Healthy Chicago 2025 is lasting. So you can go to the next slide. Okay, so here are the primary goals for Healthy Chicago 2025. As you know, if you mentioned through the MAP assessment, these all emerged from what people were saying from both the public health system and community members. And I wanted to identify, as we did the assessment, much of the data identifies deficits within the community, and that is common, and that is what we usually see. However, to do this, we also, people and community members, identified opportunities and strategies and assets, and we're really framing the plan to tell the full story and highlight those assets within the communities. So you should be able to see that in the way that we have stated our goals. Also, one of the key findings was to focus on upstream concerns such as racism, structural inequities, and institutional inequities, again, on the Bar-High model all the way to the left side of that. And we are doing that through our Goal 1 and Goal 2, the first one being transforming policies and processes to foster anti-racist multicultural systems, and is a really important part to look at our policies and start making some changes in that, because otherwise the health conditions might change, but they're not going to be sustained unless the policies and the institutions are changed. Also really came out strongly, and which is really a key component of health equity, is community capacity, especially related to youth leadership. So we will be focusing on identifying policies and systems that will really strengthen that work. We also focusing on systems of care with goal number 3, and as we just heard through a lot of people mentioning behavioral health and improving and growing that system, and is essential to the health of Chicagoans and throughout the whole region. So we will be focusing in on that. Also to address infant mortality, there's a focus on maternal and child health. And again, even in this day and age of the internet and so many resources, we definitely heard over and over that people still didn't know how to access care, even just the basic access of care. So really building that along with strengthening patient navigation and health literacy, and also connecting that to goal 2 of community capacity, so people can feel as they can take a little little bit more control of accessing the resources that they need. And then also to addressing the living conditions, which is key to actually meeting those life expectancy goals, is furthering the health and vibrancy of neighborhoods most affected by these inequities. So as you can see here, we've listed 5 that sort of were really highlighted and came out in the assessment as we went forward. So you can go to the next slide. And then the last slide I just wanted to mention, you know, as we try to limit our priorities, what we felt really important that these guiding principles were essential to mention. So you can see what we're doing now. So for each of those goals and those sub-goals that I mentioned in the previous slide, people are identifying 1 to 2 strategies for that. And each of the strategies of work groups are going to be focusing on making sure that the strategies infuse these guiding principles within their work. So I know many of you have joined these work groups, which should be starting later this month, and part of the work will be finalizing the strategies that came out through the assessment, and then really looking at that strategy and making sure it does these things like redressing racist systems, that it institutionalizes community power, that it looks at wealth building within the community and within the work that it's doing. So that's sort of the call to that work that is going to be happening. So I guess just that was a real quick overview. If people haven't signed up for the group, you can contact me, and they're going to be big, but we still welcome all your input on that and this opportunity to really work collaboratively, because I think that's what all the Alliance is about. And so we can work on all of these areas and really make some changes. So that's all I have on that.
Thanks,
Great.
Sherry.
Thank you, Sherry. And go ahead, Kelly.
Okay, great. Thanks, Jess and Sherry. My name is Kelly Day. I'm the Director of Operations for Lurie Children's Healthy Communities. And like my co-presenters, we have all participated in the collaborative CHNA process for the next, what Katina said, 14 to 18 months. It's definitely a labor of love. In addition to our partnership on the collaborative CHNA, we were also working on data collection and analysis for our own CHNA, like my co-presenters. And for our assessment, for Lurie Children's Assessment, we defined our community or our service area as children and adolescents living in the city of Chicago. And we also did some primary data collection, which included focus groups with our patients and then other youth in the community and their families. We also collected community input surveys with really a focus on elevating youth voice, specifically targeting those under 25 years of age. Through this process, we refined our community health goals from our last CHNA to really emphasize improving health and well-being for children and adolescents and advancing health equity for youth and their families. Considering the family context for each child is fundamental to us as a children's hospital, and it also aligns with the collaborative CHNA's priority health issues, which I will discuss shortly. So nearly 1/4 of Chicagoans are between the ages of 0 and 19 years old, and this first map shows the pediatric population density by zip code. And you'll see the darkest purple indicates the zip codes with the most youth. And you can see those are predominantly on the south and west sides of Chicago. Chicago is unfortunately one of the most racially and ethnically segregated cities in the US. The second map, which the full map of Cook County just showed on slide 18, this one focuses just on the city of Chicago. And it illustrates the segregation, showing the predominant racial and ethnic groups by community area. The blue teal colors represent African Americans, pink coral colors represent Latinx, the purple and lavender represents Asians, and the yellow and orange colors represent whites. The darker of the two colors indicate where the predominant racial and ethnic groups make up more than 70% of the population. And then the last map I want to show you, it shows the Child's Opportunity Index, which is a composite measure of 19 variables related to social economics, education, and health. It includes things like housing and food access and how close you are to health clinics and green space. The dark red, the red and dark red indicate communities with low or very low child opportunity index. So these maps taken together highlight that the areas in our city with the most children are highly segregated, and predominantly Black and Brown communities with the lowest social, economic, educational, and health opportunities. So I mentioned that one of our goals and really overarching aims of our assessment, and will be a part of our implementation plan, is to elevate youth voice, which also aligns with Healthy Chicago 2025. We had over 100 youth complete a youth voice survey, which was based on the community input survey that the Alliance developed. And I won't go into a lot of detail because we heard a lot about the community input broadly, but I did want to highlight that the youth that took our survey were between the ages of 13 and 25. And they identified some of the same health issues that the young adults, which Leah and Andy discussed earlier, including substance abuse, violence, and mental health as top priorities. A key somewhat difference is that more than half of respondents chose substance abuse and violence as their top concerns. They also identified diabetes and obesity as top concerns, and so that's really an important factor in what we're going to be focusing on. We also asked youth the same questions about what's needed for a healthy community, and the interesting thing in our data was for Chicago youth, they also identified safety and low crime, access to health services, clean environment, but they also, nearly 40% identified good schools as a really important factor for a healthy community. So in addition to the community input collected for the collaborative CHNA, which was very extensive and amazing, we went into details about that previously. Lurie Children's also conducted interviews with 45 parents and caregivers and facilitated 6 additional focus groups with 125 patients and their families, youth and families in the communities, and our employees. And one note too, in our community health needs assessment, we reference social and structural determinants. In our implementation plan going forward, we are intentionally transitioning to use language around influencers instead of determinants. Determinants is a little fatalistic, right? It's a little bit of a foregone conclusion, and we really want to put that power back in our communities. And so we want to acknowledge that these factors influence health, but they do not determine someone's health. We know that we can interrupt that and actually result in positive health outcomes. So social influencers of health were discussed across all the settings, which also included food insecurity, housing stability, opportunities for youth, and transportation. Our non-patient community participants in particular highlighted discrimination and racism as serious issues, which also intersected with immigration and family separation, safety, and relationships with law enforcement as well. I won't go into any more details, but we have a full community input section in our community health needs assessment, which underscores some of the similarities and alignment with the collaborative CHNA, which was countywide, and some of the differences in Chicago, specifically for youth under the age of 25. So from the collaborative county-wide CHNA, priority community health issues emerged and were identified, and these health issues will be addressed by the Alliance for Health Equity and the member hospitals. And as you can see on this slide now, there are 6 key community health issues that arose from the collaborative CHNA. They're listed in bold, and those include social and structural determinants or influencers of health, access to care and community resources and system improvements, mental health and substance use disorders, chronic conditions, maternal and child health, and injury. Many of those also align with what Sherry was talking about for Healthy Chicago 2025, which is the intention. So hospitals also use this framework to inform our own hospital-specific priority areas and identify areas of focus for our community health implementation planning. So now I'll turn it over to Jamika from Mercy Hospital to discuss how they prioritize community health issues.
Good morning. My name is Jamika Sampson, Director of Community Health and Wellbeing at Mercy Hospital and Medical Center. I'm going to discuss how we prioritized our health issues. In March of 2019, we held a stakeholder meeting after an invitation was sent out to cross-sector community organizations, and Dr. Angela Odoms-Young of the University of Illinois, Chicago facilitated our session. Our group reviewed and ranked health outcomes of concern at the individual, system, and community level, and each participant had the opportunity to ask questions and discuss the size, impact, and readiness of the community to address the problem. After the discussion, each participant was given the opportunity to vote on their top 2 or 3 needs in each category. I will note, as other presenters have said, our group really thought it was important to acknowledge the impact that structural racism and inequities have on each of the listed health issues. And we thought that it was important to note that the impact of racism and inequities needed to be addressed in order to see long-term changes in these marginalized communities. We prioritized our targeted health issues based upon the community input survey, and our participants were pretty much in line with what the community said. They ranked them in the same order, with diabetes being the top most prevalent issue that needs to be addressed, substance use, violence, and mental health. During the discussions, it was brought up that some of these are interrelated and some upon each other. Some of these health conditions influence the others. For our access to care, community resources, and systems, we prioritize also using a question from the community input survey and the framework that what Kelly reviewed, the Alliance framework that was on the previous slide. So the question was, what are the 3 most important things necessary for a healthy community, and identify priorities from and that influenced this question. We ranked resources, referrals, coordination, and connection to community-based services as a top access to care priority, and trauma-informed care. That was what our stakeholders found to be important. The Alliance identifies social and structural influences of health. Mercy Hospital and our system also use the term social influencers of health were prioritized based upon the stakeholder knowledge of current interventions and their beliefs on what was most pressing and what the community was ready to address. And with that, we prioritize economic vitality and workforce development, and violence and community safety, also recognizing that these 2 have been shown, research shows that they influence each other. This information will be used to inform our implementation plan that is due in mid-November, on November 15th. Next slide, we have a question for you all. What are priorities that you are interested in? Great. Great. So our poll results show that social and structural determinants of health is number 1, with mental health and substance use disorders being number 2. Social and structural determinants of health received 41% of your vote, and mental health and substance use disorders received 22%, followed by housing and health and community safety and trauma and resilience, at 11%, and food access and food security at 15%.
Great, thank you so much, Jamika. Those who are paying attention will note that we're a little bit behind on time, and we want to make sure to get to the couple questions that have come in. So as was mentioned at the beginning of the webinar, unfortunately, Christopher Nolan from Rush was not able to join us today, but I do want to share a little bit about what he was going to present in a few minutes here. Next slide. So this is a lot of information, but we wanted to provide it particularly in the handouts for you for your reference. So the goal in terms of moving forward and collaborating on next steps was to look at the ways that healthcare institutions are already partnering with communities and others of you on the phone around the priorities. So we provided here the crosswalk of different collaborative initiatives that we took into account in thinking about where we are going to focus as the Alliance for Health Equity and leading some collaborative strategies. Next slide. You also have the information about what all of those acronyms on the previous slide stand for in case you need them. Next slide. So this slide shows some of the work that Rush has done on their community health implementation plan. And I know that Christopher and others there would be happy to answer more detailed questions if you have them. What we wanted to point out is that this is an example of how one of the hospital institutions has laid out the strategies and initiatives related to the social and structural determinants priority. And you can look at the priorities that they have around education, local hiring, investing and spending with local businesses. And also you can see how those relate to areas that the Alliance for Health Equity, Westside United, and the Chicago HEAL Initiative are all working on. And several other hospitals have been doing this as well, so that we continue to connect up our work and build towards collective impact by working on strategies that other hospitals, community partners, and health stakeholders are already working on. Next slide. We provided here a little bit of information about how communities have been involved thus far in interpreting and defining partnership strategies. Next slide. And we wanted to let you know that there are multiple ways for you to get involved if you are not already in the strategies related to the priorities that we're working on through the Alliance for Health Equity. So based on the poll that Jamika just administered, many of you on the phone are interested in the same priorities that we have selected to work on. So if you think back about 5 minutes to when Kelly was presenting the priorities, you know that there were 6 categories of priorities that came out of the CHNA. We have decided to continue to focus our collective work on social and structural determinants or influencers of health, mental health, and substance use disorders, because we heard loud and clear from communities and from healthcare partners that those were the areas where we really need to work collectively to really make a difference on some of the inequities we see in communities. This is not to say that individual hospitals are not working with all of you on the other priorities. As Jamika just pointed out, they have a number of different strategies that they're working on. Those that line up to the Alliance for Health Equity strategies will be happening collectively here. If anyone on the phone is interested in getting involved with any of the work groups or committees listed here, please don't hesitate to reach out to Andy at the email here on the slide. We would really love to have folks' involvement. So I know we've had a couple questions come in already, and we move to slide 38. Then you can see where you can submit other questions that you may have. I know one of the questions that came in was whether one of the speakers on the phone could give an example of how your institution is, how your healthcare institution is thinking about addressing racism within the institution and addressing structural racism through your community health strategies. So would one of our healthcare partners like to share a little bit about how you are working to address racism through your community health strategies? I think that we will unmute all of the presenters, and hopefully someone can give us an idea about how you're starting to think about addressing racism within your community health strategies.
Jess, this is Kelly Day with Lurie Children's. I can answer this question. It's early for us. We're still in the process of developing our implementation plan, but we are integrating a racial equity lens throughout. So it's the questions, you know, how are our choices for strategy potentially impacting communities of color, specifically Black and Brown communities. I don't want to lump those. We want to be intentional about acknowledging that there are disparities specific to Brown communities and specific to Black communities. And so we are very cognizant of that. And so we're not lumping them under this umbrella of communities of color, but looking at them specifically. Additionally, we are exploring a specific strategy to address racial inequities within our own institution, addressing implicit bias and trying to kind of look internally before we even start trying to step externally on this issue. We need to make sure that we're doing everything that we can do within our own institution, with our own physicians and clinical staff and our own patients. And then with all of the work that we're doing in the community as well, we are intentionally asking ourselves these questions and ensuring that we are inviting diverse voices to the table to make sure that we are asking these questions and integrating that into whatever strategies go forward. So we will have a strategy to be determined that's focused around racial, or addressing some of the racial inequities within our own institution, and more to come.
Thanks, Kelly. And unfortunately, we don't have time for others to share right now, but I will mention that the steering committee for the Alliance for Health Equity has decided that structural racism will be one of the focuses for shared learning across the healthcare institutions within the Alliance. And also, we as Alliance staff, Jenny Turner on our staff was a Chicago United for Equity Fellow this last round, and we've been working with the work groups to incorporate the racial equity impact assessment framework into the way that the work groups are functioning. So more to come, but really appreciate that question. I know we had another question that came in about data for veterans. We had one focus group specifically with veterans in South Suburban Cook County, and there was other information about veterans that came up through the community input. We did not have specific secondary data for veterans. However, we're happy to follow up with the person who asked that question and find out if you have additional data or if there's data that we have that we can share with you. With that, we will have to wrap up the webinar today, but please submit any additional questions or comments that you have, and we will address those either individually back to you or back to the full group if it's relevant. We really appreciate everyone's participation and particularly the presenters on the webinar today, and look forward to working with hopefully all of you who are listening in on addressing these priorities moving forward. So on behalf of the IPHI staff here and on behalf of our wonderful presenters, Katina Latham, Jackie Rouse, Kelly Day, Sherry Cohen, and Christopher Nolan, and Jamaica Sampson, sorry. We really appreciate all of you for your participation today and look forward to working with you in a continuing way going forward around these priorities. Thank you very much.